It gives me wonderful pleasure to introduce our next speaker. It is great joy, Dr. Diane Meyer, who is a professor in the Brookdale Department of Geriatrics and Palliative Medicine and is the immediate past CEO of the Center to Advance Palliative Care, a national organization devoted to increasing access to quality palliative care for people living with a serious illness and their families in the United States. Under her leadership, she tripled palliative care programs in U.S. hospitals. She is the co-director of the Patty and J. Baker National Palliative Care Center as well. She has received numerous awards, including the MacArthur Foundation Fellowship. She was a Health and Aging Policy Fellow. She has published over 200 peer-reviewed publications, and she is going to talk about a very interesting topic that I think you will all enjoy hearing, something that I think we commonly encounter in practice, and really seeking some ideas for screening and resources as well, and just a conceptualization of thinking about just the concept of loneliness and human connection. So, Dr. Meyer, thank you for being here today.
Thank you so much, Helen. What a lovely introduction. So I titled my talk, All You Need Is Love, from the famous Beatles song. And I could probably stop there and we could all go home, but I'll show you the science behind the evidence that loneliness and social isolation are really bad for your health. So this was a picture from the New York Times, sort of late in the pandemic, that everyone is not okay. And I thought it was kind of a nice graphic image of changes that have occurred in our society certainly over my lifetime, and the growing disconnection that we seem to have from one another. This is the introductory paragraph of a report from the National Academy of Medicine on social isolation and loneliness in older adults. And they said human beings are social by nature, and high-quality social relationships are vital for health and well-being. Like many other social determinants of health, however, social isolation, which is a quantitative lack of social contact with others, and loneliness, which is the subjective feeling of being isolated, are significant public health risks. Social isolation and loneliness are associated with poor physical and mental health outcomes, higher rates of death, depression, and cognitive decline. Recent research just documents the very high prevalence of both social isolation and loneliness among older adults. For instance, recent data found that 24% of community-dwelling older adults are considered socially isolated, and a 2018 AARP survey found that 35% of adults over age 45 report feeling lonely. And that was 7 years ago. Additionally, a 2018 study from the Kaiser Family Foundation found that 22% of adults, all adults in the US, say they often or always feel lonely, lack companionship, feel left out, or feel isolated from others. I don't think we would have gotten these results 30 or 40 years ago. So, as mentioned earlier, social isolation is not a feeling. It's a quantitative measure. It's measured by the quantitation is the number of other human beings that an individual is in contact with during a day. So that could be the person from Meals on Wheels. It could be the doorman. It could be the ambulette driver. 25% of people over 65 are socially isolated, and being socially isolated, as mentioned before, is associated with increased risk of death, a risk increase equivalent or greater than the risk associated with obesity, smoking, or inactivity. We screen for obesity, smoking, and inactivity. We do not screen for social isolation, but we should, because it is a major risk factor for not only illness and death, but also cognitive impairment. Loneliness, in contrast, is subjective. You could see 100 people a day and feel lonely. About a third of adults over the age of 45 report feeling lonely. Those who feel lonely have higher rates of depression, anxiety, and suicide. Among heart failure patients who are lonely, a study found a 4-fold increase in the risk of death, and a 68% increase in risk of hospitalization and ED visits. And we all know how important it is to many stakeholders to reduce hospitalization and ED visits. So screening for loneliness is really an essential part of increasing the chances that patients can remain at home. The risk of loneliness is very high among immigrants, especially first-generation LGBTQ people, victims of all kinds of abuse. This really important study published in JAGS 3 years ago, which I have been told is on the boards, or questions related to this are on the boards. This was titled Bad Company: Loneliness as a Longitudinally Predictor of the Symptom Cluster of Pain, Fatigue, and Depression in Older Adults. So what they found in this study, and I recommend that you look it up, is that the more severely lonely someone was, that's an independent predictor of the future development 8 years later of pain, fatigue, and depression, and the cluster of all 3 symptoms. And this is after controlling for baseline pain, fatigue, and depression, as well as living situation and socioeconomic status. So the early identification of loneliness and the effort to try to address that could have very substantial subsequent impact on health and well-being as many as 8 years later. And of all the variables tested, loneliness had the largest effect size. And by the way, this was pre-pandemic data. In an editorial for that paper, my colleague Ashwin Kotwal and I wrote a commentary titled "A Paradigm Shift: Loneliness as a Root Cause of Symptom Distress Among Older Adults." And there's lots of other studies supporting this. So here's one of cancer survivors in the United States. Elevated loneliness was associated with higher mortality among cancer survivors, again calling for standardized screening for this variable. We've also found that social isolation is associated with hospitalization and ending up in a nursing home among community dwelling older adults, a 2-fold increased risk of nursing home placement among people with high levels of social isolation. What's not entirely clear is what comes first. Are people socially isolated because they are cognitively impaired, because they cannot make connections with others? Do they end up in a nursing home because they actually need help with activities of daily living? Or is it the social isolation itself that is leading to the need for help getting through the day? This is a paper by Ashwin published last year in the Gerontologist titled "Relationships Very Quickly Turn to Nothing: Loneliness, Social Isolation, Adaptation, Changing Social Lives Among Persons Living with Dementia and Their Care Partners." So once a diagnosis of dementia is made, very often friends fall away, neighbors fall away, even eventually family members fall away, leaving the person with dementia and their care partner quite isolated and lonely, which I think we've all seen in clinical practice. So we know that there are some statistical predictors of social isolation: being single, being male, having low educational attainment, being hard of hearing. And there's an increasing body of evidence showing that identifying hearing loss early and getting hearing aids early reduces cognitive decline, the occurrence and the rate of cognitive decline. So that's something that we can do. Being white is a predictor of social isolation, and having low income. Loneliness, on the other hand, the predictors of that are being a woman, being in pain, being incontinent, having memory loss, having hearing loss, and being low income. So we can start to look for people who are at particularly high risk for developing these syndromes. So what are the implications for us? So social isolation and loneliness and trauma and grief are major determinants of health, and we should be screening for them and intervening when we find them. And I guess the message I want to convey is that although we may feel helpless when we identify or care for patients with loneliness or social isolation, we are not helpless. And that's an important cognitive shift for us as clinicians. Most people interact with us, even the lonely and the socially isolated, often, and sometimes their major form of social contact is seeing us. And we all have patients who come up with a reason to come in so that they can get someone to care about them for a little while. For many of our patients, it is their only or most frequent human contact. If we don't look for it, we don't know and can't help. Our job is to screen, identify, and intervene, just as we do with blood pressure, hemoglobin A1C, and cognitive assessments. And there are several validated scales. The ones that most people are using now is the Berkman-Syme Social Network Index, which is basically a count of the number of individuals the patient comes into contact with, and the UCLA Loneliness Scale. So we can't control what isn't under our control, but there is a fair bit that is, and that's how we can influence the future. So this was a study done mid-pandemic, published in JAGS about 4 years ago, that looked at a representative sample of nearly 5,000 respondents. 25% said they had no in-person contact, no daily in-person contact. 50% had never used Zoom or FaceTime video, had never used video calls. There were increased levels of loneliness, depression, low overall use of assisted technology. And the question is that because many older adults are not comfortable using modern communication technology? Is it that they can't afford a cell phone? Is it that they don't have access to broadband in their neighborhood? We don't know. And what is clear from this study is we need equitable, affordable ways to enable people to use technology for human contact. And we need some studies of dose and access, how to improve access to remote technology, particularly for older people. This single question, another study from Ashwin, actually was a pretty powerful predictor, and as sensitive but not as specific as the UCLA loneliness scale. But how often are you lonely is a very quick, short question we can ask that identifies a lot of lonely people that we would not identify otherwise. And interestingly, perhaps post-pandemic, it seems to be less stigmatized than it used to be to acknowledge feeling lonely. Most of my patients answer in the affirmative: yes, I feel lonely. This is a wonderful study, almost 5 years old now, again from Ashwin, on a peer intervention. What they did was they worked with a senior center actually in the Tenderloin district of San Francisco, which is a very poor, multi-ethnic, very high levels of substance use disorder community. And they had a senior center there. And what they did was, and the people in the senior center knew the people in the neighborhood, and they knew the ones that weren't coming to the senior center anymore, whether because of mobility issues or concerns about infection or cognitive impairment, unclear. But at the senior center, they identified people who were willing to be trained as peer supporters. And they put those people through a pretty brief training, and they paid them $15 an hour. Now compare that to the cost of a CAT scan or schlepping to our office or getting lab work. I mean, very, very cheap intervention. And they matched the peer supporters to patients based on ethnicity, language. So if you were an older Chinese person who spoke Mandarin, you were matched to a peer who was a Chinese person who spoke Mandarin. And what those peers did was they called, they visited if it was okay with the person to meet in contact. They met people for coffee or tea. They helped people make doctor's appointments. They helped arrange transportation to clinic appointments. And this markedly improved social well-being in the individuals who received the services. And what Ashwin is doing now is he is funded to do a much larger trial of a similar intervention. But you could see how partnering with local senior centers could be a really effective means of addressing loneliness and social isolation in our patient populations. What is generally recommended is something called social prescriptions. So just as we write a prescription for a medicine for hypertension, we should start writing prescriptions for social interventions. So for example, visit local senior center at least twice a week and then sign your name on the prescription. Because when a doctor prescribes something or other clinician prescribes something, it carries with it the weight of a medical recommendation and may be able to help people overcome shyness, social anxiety, and particularly if you can engage a caregiver, a family member, or a friend to go with the patient, initially at least, to overcome some of that shyness and social anxiety. So this paper basically argues that in addition to our usual geriatric assessments, we need to assess the level of social connection. Individuals should be asked if they feel isolated, lack companionship, or feel left out. People should be asked, how many people do you feel you can depend upon, or do you feel close to? And we should ask our patients about their access to phone or video communication technologies. Won't take long, really instructive information. And we clinicians need to get out of our silos because there's all kinds of social supports out there, but they're not in our ivory and glass towered medical centers, but they're out there. So there's AAAs, and in every community, AARP lists resources by community. There's an elder care locator. The National Council on Aging has local resources for social isolation. It's part of our job as clinicians to find these resources in our community and to connect our patients to them. Ashwin and I developed this table of things that we clinicians can do. Identify loneliness. How often have you felt lonely? Or the UCLA scale. So some people use this suggested phrase. I've noticed that many of my patients say they feel lonely. Is that something you have experienced? to discuss with the patient possible causes. So identifying losses, death of a spouse or relative, death of friends, change in living situation, reduced opportunity because of mobility issues or vision issues or hearing issues, or memory loss. And then help the individual, your patient, process what that means. Ask if patients would like help in addressing this issue. Just providing the space to acknowledge the reality of loneliness and talk about what it feels like. Just that is therapeutic. Just being fully seen as a person by the clinician is therapeutic. And then we have to individualize our approach to intervening and to helping people find social connections. In our practice, we're very fortunate to have incredible social workers who are much more knowledgeable than I am about the local resources for older adults. And interventions might involve strengthening existing coping strategies. So like a once a month family Zoom could be once a week, could go to once a week. Things like that. Establishing referral networks to local organizations. And it is okay not to have an immediate solution and to think with your team about options over time, or even to convene a group of older adults from your practice and ask them to help you think about options over time. And then there's very high co-occurring rates of poorly managed pain, unidentified, unmanaged depression, polypharmacy and adverse drug effects, mobility challenges, which can be addressed. So all of these things can be addressed, and that they may improve the person's ability to interact with others. So this is the takeaway. Our presence and our ability to be present with our patients, to make eye contact, to listen carefully, has a huge impact. So these are quotes from patients who received a palliative care consult. Same kind of quotes come from patients and families that received geriatrics care. We didn't realize that someone still provided medicine that spoke to the experience of the patient and family. You were the only ray of light. Thank you for advocating for me. We didn't feel like anyone was hearing us before you talked with us today. I feel less alone. My only regret is that we did not find you much, much sooner. You have been a bright light in a dismal time. So our very presence in the room, sitting down, looking at the patient, being there, is a powerful intervention. So this article in the Washington Post was written by a medicine resident at Cornell in the midst of the pandemic. And what she wrote was, it's not just about treatment. We also need to make sure that our patients feel seen. And I thought that was a really important insight from a medicine resident, that being seen as a fellow human worthy of attention and care is incredibly powerful and meaningful, not only to patients, but to those who love them. And even during the pandemic, when families could not visit, nobody was alone. They had nurses, they had doctors, they had social workers, they had other people working in the hospital. They were not alone. And I think that's very important to remember, the human contact that we provide to patients. This is a quote from a longtime colleague of mine, Stu Farber, who died, I don't know, maybe about 10 years ago. He died of leukemia. Bizarrely, his wife received the same diagnosis some months after he did. They both used their time before death to reflect and write about what they were learning as patients who also happened to be health professionals. First, living with a fatal illness taught them that uncertainty is a given and control is an illusion. Second, they saw how clearly their doctors and nurses were deeply invested in that illusion of control. Yet every clinician Annalou and I have interacted with is more afraid of death than we are. They focus on solving the problem of our illness with little awareness of how we want to live. It is a paradox. The clinician is focusing on treating the illness that threatens life, but the life of the person who is ill is invisible. Third, even when he expresses his grief and sadness to them, I have been amazed at the distance my providers need to keep from my grief, and when it is touched, how quickly they are bound to fixing it. Most of my clinicians are so busy protecting themselves that being with me is not possible. As I sit with my medical caregivers, I see fear of failure at the center of their consciousness, with death being the ultimate defeat. But what he's saying here is what he wanted was his clinicians to be able to be with him as he expresses how he feels, and not to rush away from it and not to rush towards trying to come up with a fix. Just be there. And Simone Weil, who was a brilliant young philosopher, wrote this that is something I have over my desk. Attention is the rarest and purest form of generosity. And I think everyone knows that attention is really scarce and getting scarcer because of our cell phones. And it's really hard for us to actually attend in real time to the person in front of us, because we are addicted to the dopamine hit from our feeds. So what do people want from medical care? They want our presence, our attention. The number one priority for medical care is a strong relationship with us, a clinician who listens, is caring and compassionate, and explains well. So what are the implications for our care models? We're going to virtual, we're going to AI, we're basically, relationships are expensive, so we're reducing access to them, and I think that's a huge mistake. This is a book I recommend to all of you. It's called A Fortunate Man, the story of a country doctor, a man named John Berger, who is a poet, an art critic, a novelist, spent a year following a family doctor around in England for a year. He spent a whole year with him. And this is what he observed. In illness, many connections are severed. Illness separates and leads to a distorted, fragmented sense of self. The clinician, through relationship with the patient and by means of the special intimacy we are allowed, compensates for these broken connections and reaffirms the social meaning and value of the patient's sense of self. It's a great privilege being a doctor. If you'll let me, I'll read a couple more quotes. This is from a medical philosopher, medical ethicist. 30 years ago, he wrote, "The sting of illness and death is the specter of broken relationships and the loss of the world. Over and against this threat stand the efforts of caregivers and companions to embrace the sufferer and continuously affirm his or her capacity for relationship." The secret of the care of the patient is caring for the patient. Don Abedian, who was very famous, he developed the modern field of quality measurement. When he was dying of cancer, he wrote this: "The secret of quality is love." And I'll close with a poem. Mary Oliver wrote this poem called Praying. It doesn't have to be the blue iris. It could be weeds in a vacant lot or a few small stones. Just pay attention. Then patch a few words together and don't try to make them elaborate. This isn't a contest, but the doorway into thanks. and a silence in which another voice may speak. Thank you, guys. I apologize if I went over my time.
Thank you very much, Diane, for that very thoughtful talk, and really thinking about our role as clinicians and how pivotal we are in our patients' well-being. And sometimes we just very much focus on diseases and guidelines and how much the human aspect is critical. So I wanted to, if it's okay with you, to review a couple of questions for the participants. One question asks, how do you operationalize screening with the Berkman or the UCLA loneliness tools? Are these used by clinicians or other team members?
Well, to be honest, we have not operationalized them in our clinic, and we need to. But a lot of screening is done by medical assistants.
Mm-hmm.
So are you having any pain? Have you fallen? A lot of depression questions. My concern is that patients know that people are reading a list to them and that they're not the people who know them or have any relationship with them. And I worry about the validity of that over the phone with a medical assistant, whether we're going to get honest answers or not, because they are sensitive questions.
Mm-hmm.
I don't think it takes that long to ask, do you feel lonely?
Mm-hmm.
How many people do you see?
Right.
It's part of establishing a trusting relationship between us and our patients. And it's getting at the things that actually matter the most, because they are such powerful drivers of misery and ill health and cognitive decline and functional decline. And if we're not paying attention to that, we're talking to ourselves in a lot of ways, in my view. We're focusing on what we were taught to focus on, where the real issue is over here. This person is alone, basically. So, and I understand that's how we were trained, but we have to adjust to the reality of our current society and our current social situation. It wasn't this way when, this way now.
And I would think also in the fact that any recommendation you're going to give, right, would require you to understand context, would require you to understand. So these are questions that are going to help anyway in creating a patient-centered plan. So I think you bring up a great point. And I think one of the other questions that was asked of whether or not some of these interventions may not just even be peers, like we heard about that, but also kind of bringing in some of the interdisciplinary students that are often looking for opportunities, right, to interact and learn how to interact. So do you think that is something that we should be thinking about as well?
I think it just requires a little organization. They're all out there. I think the other thing that we don't pay enough attention to is faith communities, because most faith communities have friendly visitor programs for their shut-ins, as they used to call them, and mobilizing. Sometimes the person hasn't been going back to church or mosque or synagogue because they're embarrassed, memory loss, mobility decline, their friends have died, so they lost connection with the congregation. And with their permission, a call to the minister, the pastor, or the rabbi will, you can get high school students doing community service, who will visit, watch the baseball game, just hang out and talk about the war. It's not hard to do. It's just a logistical organizational challenge. And it's such an inexpensive and meaningful medical intervention. So we have to get over ourselves, like in our medical model, and pay attention to the community around us and helping mobilize the community around us on behalf of our patients.
That's exactly true. Do you think that maybe also there's opportunity not only, because many times we publish kind of in our medical journals, right, interventions where there might be opportunities to bring this out more into the lay public community, ways that that we can get that message out that really resonates with people?
I think that's a great idea. I mean, I know that many of us frequently go out and give talks to congregations, to senior centers. Perhaps we could be more proactive about that, particularly in poorer communities, particularly in communities where the language is not English,
Mm-hmm.
and try to extend ourselves really and the knowledge that we have about geriatrics and the needs of all people, but especially older people. But it has to become part of our training, I think.
Mm-hmm.
It has to become part of what we expect of ourselves. So it should be part of our training, and it isn't. And so I think that that kind of modeling, even just reaching out to the senior centers and the zip codes surrounding us in a organized, logical manner, and asking about services for people who are isolated, people who are lonely, people who can't get there. And if there aren't any, maybe we can work together to develop them.
Mm-hmm.
But it is getting out of our silos.
Yeah. Well, I appreciate your talk, and very thought-provoking, right? Thinking about some ideas already. And I think you bring up a great point. There are resources out there we don't know and that we have not tapped into, right? You probably, the participants have kind of local councils of aging where there are. And so kind of dovetailing and kind of creating that bridge. And right, I think it's even beyond what we usually think of, when we think about concepts of community participatory research. This is like really patient-centered care. So thank you very much for speaking with us today and sharing all these great ideas. And I think this really will allow our participants, and some of our participants are in rural areas at VAs, go into homes and really treat patients that probably don't get out as much and do not and are lonely. So appreciate you and appreciate this presentation. Thank you very much.
Thanks for inviting me, Helen.